fracture around the wrist joint. Common distal radius of fracture classify according to the type of angulation and relation to the articular surface. Dorsal angulation, extra-articular Colles fracture, intra-articular dorsal Barton, with polar angulation, extra-articular Smith fracture, and intra-articular polar Barton and reverse Barton fracture. Gross anatomy. Wrist joint composed of the three articulation surface, three radiocarpal joint, distal radio-ulnar joint, and midcarpal joint. With the first radiocarpal joint, concavity of the radius with proximal part of the proximal row of the carpal bone, radio-ulnar joint, and midcarpal joint. Images in the X-ray and MRI. Distal radial fracture are heterogeneous group of fracture that occur at distal radius and are dominant fracture type at the wrist. These common fracture usually occur when significant force is applied to the distal radial metaphysis. Distal radial fracture seen in any group of patients, and there is bimodal age and sex distribution. Younger patients tend to be male, older patients tend to be female. The majority of patients with distal radial fracture presented following fall onto outstretched hand. They are in pain and have reduced range of motion. May be associated with deformity and, in severe cases, distal neurovascular compromise. Trauma is almost always a cause of distal radial fracture. It is often a result of fall onto outstretched hand. In young adults, the long bone tends to be strong, and the force required to break the bone is significant. Thus, the distal radius of fracture in younger patients require much greater force. Example, falling from the significant height, severe road traffic accident. In elderly, the bone tend to have much lower bone density and are consequently much weaker. Fracture of the distal radius can occur with injury that exert much less force, falling from the standing height. The force applied longitudinally or obliquely to the hand and wrist is absorbed by the distal radius because it is the load-bearing bone in the forearm. If this force is greater than the strength of the bone, a fracture occurs. When most people fall, they do not axially load the forearm, but apply an oblique force longitudinally and dorsally. If a fracture does occur, there is usually associated with dorsal angulation. Classification described in terms of their fracture type, location, displacement, and joint involvement. Colles fracture, transverse extra-axial fracture with dorsal angulation. Smith fracture, transverse fracture with palmar angulation. This is a Colles fracture, X-ray, AP, and lateral of the wrist joint show a transverse fracture of the distal radius. There is with dorsal angulation. In this image show associated styloid fracture of the radius. Also, other image show a dorsal displacement of the transverse fracture of the distal radius. Barton fracture. There are many radiological classifications. Example, Frackman classification. It is important to recognize what makes the fracture more severe. Oblique fracture, spiral, comminuted configuration, greater degree of angulation, intra-articular involvement. Additional fractures, distal ulnar styloid, and scaphoid. Associated dislocation, distal radio-ulnar joint, Galeazzi fracture dislocation, lunate and perilunate dislocation. Associated ligamentous injury, scapholunate association. Scaphoid fracture, and there is scapholunate dissociation. Lunate dislocation and perilunate dislocation. Diagnosis usually only require standard raised X-ray series. In some complex cases, additional cross-sectional imaging, usually CT, is required to accurately assess the fracture. This is especially true when there is a multi-fracture with joint involvement. In the plain radiograph and CT, most distal radial fracture in the adult patients are transverse metaphyseal, and they are often extra-axial. But some may be extend to the joint, and when they do, it is important to recognize the degree of displacement, usually dorsal. It is important because it will be determining factor for treatment, whether they reduce or not before embolization. Describing any fracture should think about what type of a fracture is it? Is there displacement? Is there joint involvement? Is there an accompanying ulnar styloid fracture? For treatment and prognosis, treatment can be either operative or non-operative, depend on the type of the fracture, and the vast majority of this radial fracture are relatively uncomplicated, can be conservatively managed as an outpatient. Indication for non-operative management: extra-articular, radial shortening less than 5 mm, dorsal angulation less than 5 degrees or less than 20 degrees of contralateral side. Indication for operative management: dorsal angulation more than 5 degrees or more than 20 degrees of the contralateral side, volar or dorsal comminution, instability on radiograph, intra-articular fracture with more than 2 mm displacement, more than 5 mm radial shortening, open fracture, and die punch pattern. A die punch pattern هو depression fracture of the lunate fossa of the distal radius that is caused by the vertical load with a lunate. This is a depression fracture. Colles fracture, a very common extra-ocular fracture of the distal radius that occur as a result of fall on outstretched hand, consists of fracture of the distal radial metaphyseal region with dorsal angulation and impaction, but without involvement articular surface. الكوليز fracture يعتبر هو most common type of distal radial fracture and are seen in all adult age group and demographic. They are particularly common in patients with osteoporosis. They are most frequently seen in elderly women. Relationship between Colles fracture and osteoporosis is strong enough that when older male patient presented with Colles fracture, he should be investigated for osteoporosis because his risk of hip fracture is also elevated. Younger patients who sustain Colles fracture have usually been involved in a high-impact trauma or have fallen, example, during contact sport, skiing, or horse riding. Mechanism. Most Colles fracture are secondary to the fall on outstretched hand with a pronated forearm in dorsiflexion, the position one adopts when trying to break a forward fall. The proximal row of the carpus, particularly lunate and scaphoid, transfer energy to the distal radius, both in dorsal direction and along the long axis of the radius. Most fractures are therefore dorsally angulated and impacted. This is the type of the angulation, dorsal. This image, AP and lateral, show a Colles fracture metaphyseal transverse with dorsal angulation. This is another image, show a dorsal angulation. A number of classification systems exist for distal forearm fracture. One of more popular is the Frackman classification system, although it failed to distinguish between the Smith and Colles fracture as it is based on the AP radiograph. As such, in clinical practice, the use of the term Colles fracture with an appropriate description of any associated injury is sufficient in more instances. Plain film usually sufficient, although if there is any concern of intra-articular extension, CT may be beneficial. Plain radiography series often compromise AP and lateral view. It is not uncommon for oblique view to be included. The fracture appear extra-articular, usually proximal to the radio-ulnar joint. Dorsal angulation of the distal fracture fragment is present to a variable degree, as opposed to a polar angulation, Smith fracture. If the dorsal angulation is severe, a dinner fork deformity may be described. There is also impaction with resultant shortening of the radius. Associated ulnar styloid fracture is present in up to 50% of cases. This is complicated cases if the dorsal angulation is severe, like a dinner fork, and this is associated with the styloid ulnar fracture. For report checklist, in addition to noting the presence of the fracture, a number of features should be sought and commented upon. The degree of dorsal angulation, degree of impaction, degree of direction of displacement, location of the medial fracture line, does it involve the radio-ulnar joint, presence of intra-articular fracture, and associated fracture ulnar styloid and carpal bone. Complication, malunion in dinner fork deformity, median nerve palsy, reflex sympathetic dystrophy, secondary osteoarthritis, and extensor pollicis longus tendon tear. Treatment, the vast majority of the Colles fracture can be treated with a closed reduction and cast embolization. The cast extended from the below the elbow to the metacarpal head and hold the wrist somewhat flexed and in ulnar deviation. The cast is known as a Colles cast. Open reduction and internal fixation considered when the fracture is unstable and or unsatisfactory. Closed reduction is achieved. More than 10-degree dorsal angulation, more than 5 mm shortening, significant comminution. Smith fracture, also called Gorand fracture in the French literature, are fracture of distal radius with associated volar angulation of the distal fracture fragment. Classically, these fracture extra-articular transverse fracture and can be thought of the reverse Colles fracture. The term is sometimes used to describe intra-articular fracture with volar displacement, reverse Barton fracture, or juxta-articular fracture. Smith fracture account about less than 3% of all fractures of the radius and ulnar, and have bimodal distribution, young male most common and elderly female. Smith fracture usually occur in one of two ways, either fall onto the flexed wrist or direct blow to the back of the wrist. Radiographic feature split into three types, although in practice description sufficient. Type 1 extra-articular transverse fracture enough through the distal radius. This is the most common type, 85%. Type 2 intra-articular oblique fracture, equivalent to the reverse Barton fracture, 13%. Type 3 juxta-articular oblique fracture, this is uncommon, less than 2%. This is a type 1 extra-articular, and this is the type 2 oblique and intra-articular. Plain wrist radiography series will be sufficient for diagnosis and characterization. The fracture line is usually evident, although in undisplaced of mildly impacted fracture. It can be difficult to see, and subtle cortical breach or buckling should be sought. In intra-articular fracture type 2, the degree of articular step-off and gap should be assessed, and this is maybe required CT. In addition to reporting the presence of distal radial fracture with volar angulation, a number of features should be sought and commented upon. The fracture location, extra, juxta, or intra-articular, degree of angulation, and degree of displacement. With involvement of carpus, ensure the carpal malalignment or fracture are present, assist articulation of radiolunate and radioscaphoid joint. Treatment, treatment depend on the type of the fracture, stability, and ability successfully reduce the fracture. In most cases, this fracture can be treated in close reduction with cast application. If the fracture is reduced but remain unstable or cannot be reduced, then operative fixation is usually required. Malunion with residual volar displacement of the distal radius result in a cosmetic deformity, referred a garden spade deformity. More important, it also causes narrowing and distorted the entry to the carpal tunnel, can result in carpal tunnel syndrome. This is a garden spade deformity. Barton fracture is a fracture of distal radius, also sometimes termed the dorsal type Barton fracture. Distinguish it from the volar type or reverse Barton fracture. Barton fracture extends through the dorsal aspect of the articular surface, but not to the volar aspect, therefore similar to the Colles fracture. There is usually associated dorsal subluxation and dislocation of the radiocarpal joint. This is the Barton fracture. Reverse Barton fracture, also known as volar type Barton fracture, represented an intra-articular distal radial fracture with volar displacement. In fact, the reverse Barton fracture is a type 2 Smith fracture, oblique distal intra-articular fracture, oblique and distal articular fracture. Schuffer fracture, also known as Hutchinson fractures or backfire fracture, are intra-articular fracture of the radial styloid process. The radial styloid is within the fracture fragment, although fragment can be very markedly in the size. Mechanism of injury, either direct trauma, typically a blow to the back of the wrist, or from the forced dorsiflexion and abduction. And this is the mechanism of a trauma. Plain film usually sufficient for assessment of Schuffer fractures, although along with the other distal radial fracture. AP film can be also used to classify this fracture according to the Fragman classification of the distal radial fracture. These fractures are considered type 3 fracture. The fracture extends proximally in the variable oblique direction, from essentially transverse to the almost sagittal direction, from the distal radial articular surface through the lateral cortex of the distal radius, thus separating the radial styloid from the rest of the radius. Although often the fracture is undisplaced, depending on how sagittal the fracture orientation. Variable proximal migration of the fracture occur with an articular step which come into the contact with the scaphoid. A number of associated injuries are frequently encountered and may significantly impacted and management. Scaphoid lunate dissociation. This is especially true when the fracture line involves the articular surface near the scapholunate interval. Trans-scaphoid perilunate dislocation, ulnar styloid fracture, equate to the Fragman type 4 fracture. Scapholunate dissociation, and there is trans-scaphoid perilunate dislocation, also distal radius and ulnar styloid fracture. This is other images. Another images, styloid fracture, CT, and X-ray AP and lateral. Treatment, although these fractures are often undisplaced, they are relatively unstable and often benefit from the percutaneous lag screw fixation. In addition to reporting the presence of the fracture, a number of features should be sought and in many instances commented upon as relevant negatives. Fracture direction, transverse, oblique, or sagittal, where along the articular surface it begins, especially relative to the scapholunate interval, displacement and articular step off and gap distant, any comminution. Associated injury, scapholunate joint space, scaphoid fracture, carpal alignment, especially the perilunate and ulnar styloid fracture. The last subject is fracture around the wrist in the children, Torres fracture, also known as buccal fractures, are incomplete fracture of the shaft of the long bone that is characterized by the bulging of the cortex. They result from the trabecular compression due to an axial loading force along the long axis of the bone. They are usually seen in children, frequently involving distal radius metaphysis. These type of fracture are more common in children, especially between 5 to 10 years, due to the elasticity of their bone. In adults, the commonest form of the buccal fracture seen in the buccal fracture of the ribs. Cortical buccal fractures occur when there is axial loading on the long bone. This most commonly occurs at the distal radius or tibia following a fall on outstretched arm. The force is transmitted from the carpus bone to the distal radius and pointed of blast resistant fracture, usually the dorsal cortex of the distal radius. In the plain radiography, distinct fracture lines are not seen. Subtle deformity or buccal of the cortex may be evident. In some cases, angulation is the only diagnostic clue. This is a subtle a fracture of the Torres fracture. There is no fracture line, just convexity of the distal radial bone. Also, then another images, AP and lateral. Another image show a Torres fracture. Treatment and prognosis self-limiting and typically do not require cooperative intervention, although manipulation may be required if the angulation is severe. Sometimes a cast may be applied, but often a splint is all that is required with a period of rest and embolization. In children more or equal to 7 years and the distance of less than 1 cm between the fracture and physis mean a potentially unstable distal radius fracture is more likely than a buccal fracture. Differential diagnosis to the Torres fracture, green stick fracture, incomplete fracture along of the long bone and usually seen in young children, more commonly less than 10 years of fracture, 10 years of age. They are commonly mid-diaphyseal. هنا الفرق إنه mid-diaphyseal, affecting the forearm and lower leg. They are distinct from the Torres fracture. Usually in plain film, usually mid-diaphyseal occur in tandem with the angulation, incomplete fracture with cortical breach of only one side of the bone. Differential diagnosis, Torres fracture, more common in metaphyseal and result in the buckling of the cortex. Bowing fracture in the bone is bowed, but there is no discernible fracture, and Salter-Harris fracture. This is the mid-diaphyseal fracture in one side of the bone, AP and lateral, green stick fracture. This is another images. This is reference, thank you.